Hello everyone! Welcome to another webinar from the Steps Forward Innovation Academy. Today's topic is practical steps for aligning payment and value-based care. This is the second part in our discussion, and today we will discuss opportunities and best practices related to quality, performance, levels of financial risk, payment, timing, accuracy, and individual participant engagement within underlying payment methods. You don't need to have watched part 1 prior to this, but if you would like to do so, we will provide instruction for you at the end of our time today. Please note that this webinar is for informational purposes only and is believed to be current and accurate at the time of posting. Please consult a professional advisor for specific medical, legal, financial, or other advice. References and links to third parties do not constitute endorsement or warranty by the AMA. And let's just take a moment to go over your experience today as an attendee. If you're joining us on Zoom, you will see a dark menu bar either at the top or bottom of your window. There you can access a selection of resources related to our webinar today, including the slides, our VBC Playbook, and our VBC Toolkit. You can also submit questions for our speakers to answer live today. If you don't see either of those options, select the 3-dot More button to access the resources and Q&A. If you're joining us on YouTube or LinkedIn, welcome. You can follow the link in the description to join us here on Zoom, access the resources, and ask questions for our speakers to answer. Once this event concludes, you will be presented with a brief 2-question survey. Please take a few seconds to give us your feedback, as it helps tailor our programming choices to your wants and needs. After our webinar concludes today, you will be able to claim 0.75 continuing medical education credit hours. You can follow the link in the Resources tab to the AMA Ed Hub and claim the credit there. Also in the resources, you will see a link to our upcoming webinars. Check out the programming we have planned for the rest of the year and register there all in one step. We'll remind you all of this at the end, but for now, I would like to introduce you to today's moderator, Chris Botts. Chris, take it away.
So much, Alec, and thank you so much, everybody, for joining us today. We're really thrilled to have part 2 of this discussion around underlying payment methodologies within value-based care arrangements. As with part 1, we're going to spend some time describing the current landscape associated with challenges with these underlying payment methods, and we're going to be discussing specific proven and promising strategies to ease and overcome barriers to these payment strategies. And then lastly, we'll be referencing our playbook, which includes real-world best practices that help healthcare organizations sustain and adopt value-based care arrangements wherever they may be in their journey. With that, next slide. I'm thrilled to be joined by 2 amazing panelists. First is Dr. Francis Mercado. He's the Ambulatory Associate Chief Medical Officer at Franciscan Medical Group, and which is one of the AMA's health system partners. And then Karen Smith, who's a medical director and private practice owner at a family medicine practice of Karen L. Smith, MD, PA. And as Alec mentioned, I'm Chris Botts, Senior Manager here at the AMA. Next slide. So for those of you that may not have joined us for our part 1 of this series, just a brief recap about the playbooks that we developed under the rubric of our Future of Value initiative, which was a collaboration between the AMA, AHIP, and the National Association of ACOs, focused primarily on advancing voluntary adoption of value-based care arrangements, specifically focused on ways to align best practices that can help ease participation in these initiatives. This initiative is really focused on sharing what works, influenced by those folks, like the folks we have joined today, that have experiences participating and leading these arrangements in real-world settings. This is developed by those folks that have been working in the space and really understand what it truly means to be able to succeed in these arrangements on the ground, not in theory. Next slide. As part of the development of these playbooks, we focused on a number of different strategies, which include 1, an advisory work group that included both Dr. Smith and Dr. Mercado, who are members of the AMA, along with other members of the other partner organizations between AHIP and NACOS. We also had committees associated with staff from each of the organizations, and of course, a literature review, environmental scan, as well as supplemental interviews with subject matter experts for folks that might have specific insights into specific payment methodologies that we covered in the playbooks. As part of all these strategies, were really intentional in terms of who was part of these work groups. In the appendix of the slides, there's a full list of the members, but we really wanted to make sure there was a diverse representation within those discussion groups, which included national regional health plans, large, small, integrated, and independent practices, just like we have represented in the panel today, as well as other organizations like accountable care organizations, all of which had a range of experience within value-based care arrangements in terms of both substantial and also folks that may be a little bit newer to participating in value-based care. All of this was with the goal of ensuring that the outcomes of this work were representative and actionable to anybody, regardless of where they were on the spectrum of participating in these arrangements or the care settings with which they participated. Next slide. As mentioned in the first part one of this series, collaboration and flexibility were huge themes across the playbooks that we participated and developed, really ensuring that there's a balance between one, alignment between all the different parties and the development of these arrangements, and then two, ensuring that there's enough flexibility that these arrangements meet the needs of those folks specifically looking to participate in these models. And along with that, transparency was a really key piece, regardless of whatever best practice or domain was discussed. Without transparency across these different stakeholder groups, there really isn't trust in order to get to the end goals that we're all striving to accomplish as part of these arrangements. Specifically within the payment playbook, there were also additional considerations that we talked about, including around rural geographies, multi-payer alignment, and health equity. The group really recognized that in rural settings, there really needs to be a lot more specific designs and methodologies focused on those populations. They are very different from participating in other geographies, and recognize that more work needed to be done in order to better support those folks that are located in those geographies. As well as underscoring the importance of multi-payer alignment. I don't think it's a surprise, but I'm sure Dr. Mercado and Dr. Smith can talk about just the administrative burden of having to navigate various different requirements across different arrangements, different payers, etc. It really just takes away from the goals of participating in these arrangements, which is truly being able to enhance patient care for the populations that they're serving, as well as the recognition that health equity is critical as part of gaining truly valuable care. All the different playbooks or all the different domains and best practices really took this into account, but also wanted to recognize that this work is pretty nascent, and there's a lot of work that still needed to be done to pilot specific best practices before spreading them on a national basis. Next slide. So as mentioned in our first payment webinar, we specifically focused on patient attribution, benchmarking, and risk adjustments. Today, we're going to be focused on the last 4 domains in the playbook, specifically around quality, performance, impact on payment, levels of financial risk, payment timing and accuracy, and incentives for VBC participating practices in the performance under these arrangements. And with that, I believe I'm passing it over to Dr. Smith to kick us off. To you, Dr. Smith.
Thank you, Chris. We really appreciate that wonderful overview. And we are pleased to state that even though we're an independent rural practice, I am a solo practice owner with a family nurse practitioner. The strategies that we use are very much similar to our colleague practices in the ACO who may be multi-specialty, who may be in a larger metropolitan area. And as we go to the next slide, one of the things that we want to pay attention to is what were the key practice strategies for our practice for the ACO? And we had to think about what we had done at this point in terms of development of our practice model, uh, grasping those population health lessons that we all prepared for, the MIPS, everything that we prepared for, even right down to selecting an electronic health record system that was going to allow us to gather the data. And what was the data? The data is that of the every patient physician encounter, the relationships that we have with those patients, and pulling all of that information together. Well, when we came together as our individual practice, as part of the value-based care entity, which is our ACO, as part of that health plan, there were pretty much some key metrics that we were looking at. And those metrics were predetermined. Those metrics had already been pretty much negotiated, but they were also metrics that were found across the practice spectrum, whether it was my practice in rural Rayford, North Carolina, or whether it was a practice on down east in Wilmington, North Carolina. And so that was the neat thing about it. We were already utilizing those lessons already learned. Now, we have to achieve expected outcomes. So, for example, hypertension. Should we be navigating toward the threshold of a blood pressure of 130 over 80 for across the practice spectrum? Or should we be looking at 139 over 89? What that matters. Those few data points matter because when we're talking about crossing a quality gate, meaning what the ACO, the practice has come together and said in the plan that that goal blood pressure would be 139 over 89, we need to cross that quality gate in order to really look at achieving the incentive payment. If we don't, then we run the risk of loss. And so, how do we do that? How do we even come up with the statistics that make sense to come up with the numbers of something that we can really achieve and not set ourselves up for loss? Once that was done, we had to have practice buy-in. And the buy-in has to be for long term. It can't be, well, we're going to look at it for this year and then next year to be something different. And so it was a long-term buy-in because quite frankly, all of us were setting up our practice teams. We were getting our folks ready with the effort of not only delivering high quality care, but to actually receive a reward, enhanced payment for best practice behavior. We also had to look at the value-based care in terms of a unity. What are the other practices doing? For our individual practice to use that common data platform that was shared amongst our other ACO colleagues, making sure that everybody was looking at daily huddles, making sure that we had our practice specialists, those individuals who are part of the ACO to help us navigate some of this data, the education sessions, sitting with other practices, all of our practices, my MA, their RN, their physicians, we're all sitting and we're going through and we're learning the same education components that allowed us to achieve those goal metrics, whether it was blood pressure or A1C, what were the metrics that we were looking at? And then bringing all the practices together and saying, okay, your practice might be 150 miles or 500 miles from my practice, but all of us are going to come together and we're going to share, what was working, what wasn't working. So what were those practice conclaves and what was the value of that? And we never want to forget to have year-end celebrations, whether we achieve what we had set out to do or whether we came close to it. So that made a difference. So those were those key strategies that just to keep in mind, how do you go from not being part of a value-based care entity to actually coming together as a unified group? If we go to the next slide, one of the key things that we want to pay attention on is emphasis on progression. Just continue to strive forward, continue to meet those defined targets. Again, as I stated before, we might meet the target. We hope to meet the target. But if we don't meet the target, that doesn't mean that the practice has not achieved some type of benefit, that the patient has not achieved benefit because they have. The quality of care has been achieved because we are actually thinking about what will make a difference in that patient's life and the patients as a whole. And so we meet on a regular basis to review our performance. We want to further strategize. It's kind of like that plan, do, study, act. So we want to further, strategize and figure out, okay, so what do we need in order to enhance that potential for crossing the metric quality gates, assessing data. And we're getting data from all over the place, and we recognize that. But as a participant in the ACO, I also recognize in the ACO level that they are looking at that data and they are actually providing suggestions. So reviewing that information with a trained support staff actually helps to enhance the practice team. The bottom line, we're not in it alone. We're working as a team. We're working with other practices, and we have an ACO platform with shared data. And that's what really helped us to be successful. Okay, we can go to the next slide. So when we look at the quality performance impact on the payment, again, incentivize the quality improvement and sustain long-term high quality care, especially in those areas where there may not be an immediate return on investment. And rest assured, as being part of an ACO since the year 2018, it is not always going to be a return on the investment, but we continue to move forward. And then how do we continue to incorporate that high quality performance, counterbalance some of the competing financial incentives, and then and make sure that we are lowering our avoidable and unnecessary costs and promote expanded patient access, particularly in a community such as mine. And one of the things that I have found is it doesn't matter what the patient's insurance is, we continue to provide the same level, same quality of care across the board. And interestingly enough, that in itself does help to even the playing field in terms of a patient receiving benefit. And then paying attention to that clinically complex population. What I do for that population, we may have to enhance it, but the goal does not change. And so when we look through everything that we're doing, setting the quality targets that are achievable and incentivizing continual improvement and appropriately weighing the quality measures against the financial savings when we're evaluating that overall performance. So if we go to the next slide. Okay, and so we want to make sure that we are structuring that quality component in the value-based care payment system. Summary: set achievable quality performance targets, establish a minimum performance threshold, and making sure that we are rewarding the higher quality improvement. Allow for the bonus dollars to move forward for the quality improvement, regardless if the cost target is achieved or not. Adjust both the savings and the losses based on the quality performance. And keep in mind that our historically marginalized populations take into account when establishing those quality targets. And then transparency. I can't say this enough. And this is where the leaders come together. This is where the practice champions come together, that we're going to have transparent quality measures, that the methodology, that the performance targets at the start of the performance period, and the regular feedback on a regular basis, that makes a difference. So that's what we are in terms of setting up that quality performance impact on payment. And now I'm going to turn it over to my colleague in terms of looking at the levels of financial risk.
Thank you so much, Karen. As you mentioned earlier, it's about progressing, right, and progression. And you can see that with levels of financial risk because you are going through a transformation, as you start this journey towards value-based care. And it's a stepwise journey to some extent. And through those various steps, you have to go through progression and improvement. And it sometimes, requires some cost, some investment, but it's a journey. So if you go to the next slide, it's really a transformation from starting to get incentives and payment and revenue from activities that really improve the patient's quality, improve the patient's overall cost of care and cost utilization. And it's based on your attributed population. So it's the patients that you actively take care of in your system or in your practice. And it's very rewarding because right now, for a lot of Americans, you're getting paid for just the work that you do and not necessarily for the improvement or the quality or the overall transformation of that patient's health. It's really just for the work. So that's fee for service. But as you progress through value-based care, you get more rewarded for the actual care improvement that you provide. And that's transformational. So if you go to the next slide, this is a really great graphic that I borrowed from my colleague, Dr. Palermo, where you can see the progression from a fee for service to pay for performance, all the way up to capitation. And our system, for example, is somewhere in the middle, where we have some shared savings cost of care, some risk proof or just upside only cost of care revenue generation. And to some extent, we also have some employee value contracts and bundled payments. So it's a continuum. It doesn't mean that you're just stuck in one step. Now, another important part of that continuum is as you go up, you do need more investments. You need some additional employees, some additional capabilities. And it's not just certain individuals or certain employees that you need, but sometimes it's analytical capability, being able to process big swaths of data to find out where your opportunity lies. So that's something that you need to consider. Sometimes it's looking for a particular vendor to get that particular part of analysis that you'll need. And sometimes it's even partnering with service providers, anything from care managers or nurses, or even care management systems. So it's a whole wide breadth of opportunities that you could really look into to improve the care for your patients. And as you go up, you see that your level of financial risk also goes up, which means the upside or the possible revenue from this activity increases, but also the downside, the risk, because there is always that potential to fail and not get that revenue. The most important thing, as Dr. Smith mentioned earlier, is progression. You keep improving, you keep getting that ability, that capability to improve from one step to the other. So if you go to the next slide, it's really important to start aligning incentives for the total cost of care management, and really the quality and patient outcomes with that level of financial risk. So as you improve, you want to make sure that you start also improving your capabilities. At the start, we started with one care manager to take care of our small population, our pilot population. But as we found out that we can do this and we are able to not only see the patients and get paid for every visit that we do, but as we improve the patient's care and improve the patient's continuity of care, so in between those visits, we're able to reap some of the rewards as well. We started with patient-centered medical home projects and pilots, and then we graduated into shared savings and upside-only shared savings, also through the Medicare Shared Savings Program, and then finally going to the upside downside where we do have that financial risk. So really looking at your readiness, your own readiness to start and then to progress. Are you ready to take that next step? Are you ready to take on that additional risk? Do you have the care managers? Do you have the clinical pharmacists? Do you have the analytical capability to look at all of the data that your partners will start giving you to take on that risk? It's all about being ready and making sure that you're ready. And then, as you go through that process, you have as you get that capacity, it's just a matter of making sure that everybody around you is ready for it as well. Your leadership, your employees, your employee providers, your partners who are independent providers. At our ACO, Rainier Health Network, we also have independent practices that we partner with that you want to make sure that they're ready as well. Next slide, please. One thing to really think about is you want to enter into multi-year arrangements, because you can't build all of this in a year. You can't build all of this in 2 years. Sometimes it'll take you 3 to 5 to 10 years to build all of this capability and all of this ability and analytical ability. So you need to make sure you have a clear long-term strategy. You also want to be able to have some flexibility, because sometimes, when there are some challenges, you may want to consider going back to an upside only arrangement if things are starting to become difficult. And we've done that in the past too, where you see the forecast where the risk is going to be too great in the next few years. Maybe it's time to go back to an upside only arrangement for a particular population. And as you do that, you also want to look at local market dynamics. So it's interesting. Every state is different. What we're doing here in Washington State is very different from what others are doing in California, for example, where there is a lot of capitation. It's also very different from all of the other practices in the East or Southeast corridor. It's all different. So you have to look at local market dynamics as well. You do want to offer a menu of mitigating risk and risk corridors to your partners as well. As I mentioned earlier, we do have independent practices that are in various stages of value-based care as well. So we are able to tailor that to the practice wherever they are and really meet them at their own capability. So we have practices that share on the upside, downside. We also have practices that are upside only. It's important as an ACO that you're able to offer that flexibility. And there have been times where we've had to waive downside risk for these practices to make sure that they are still engaged and they are still able to partner with you. So if you go to the next slide, want to hand it back to Dr. Smith for payment timing and accuracy.
Hey, thank you so much, Dr. Francis. I'll ask our team and all of those who are online and listening, take a breath. I really want you to take a breath right now, because the payment timing can make or break your value-based care participation. That the whole, whatever you're trying to achieve, because it really does necessitate that each practice have awareness of the income expectations and your cash flow needs. And this is the business of what we're talking about. So when we look at our VBC arrangements, we have to understand that for some of us, it's only one component of practice finances. And Dr. Mercado has already stated that there are different regions or different markets, and they're not going to be the same. I'm happy to be in North Carolina. It's not going to be the same as what we may see up in Ohio or California. But the bottom line is, for my individual practice, if I'm going to really participate as part of this arrangement, I need to know what are our strengths, what are our weaknesses, where are the opportunities, what are the threats, that same old SWOT analysis. And that will reveal what areas do we need to address for optimal performance. Something so basic. Some of us have a tendency of December 30th, we're enjoying all of the holidays and we're going to close our charts on New Year's Day. Well, you just missed the cutoff for a lot of our data to go in if you decide that you're going to close charts out on January 1 of the following year. So simple as timely claim submission can have an impact on the entire process. And that is a major problem that I hear from some of our colleagues. So, what is the workflow that needs to change in your own individual shop in order to be successful? And so when we look at the VBC entity, which again, the ACO, our practice, the health plan, we need an in-depth submitted claims review assessing what is the cost of care and those quality metrics. Now, this is where a lot of physicians kind of say, that's it, I don't know any more of this. I'm not good at negotiating, and they jump out of the business model. Yeah, we're in the business model, right? And so this is where we get the expertise of that ACO or whatever our collaborative organization that we're working together, because it's going to be on that annual cycle that we're going to review all of the data, all of the claims that have been submitted, and we're going to assure that one, that information is accurate, that, where did it come from? Does it make sense? Are we missing any data? And then we're going to get ready. We're just going to get our mindset ready to anticipate adjudication. We are going to make sure that every data point that came in at a threshold that we have set, that it makes sense, that it is a true reflection of our ACO as a whole or our VBC as a whole. And we're looking for a positive adjustment. And all of this has to be completed within a defined time frame. But keep in mind, it started with the individual practice submitting the claims in a timely manner. And so some of that individual physician behavior may end up needing some help. Our practice team efficiency and the level of engagement is going to impact what the desired revenue cycle and our payment outcome. Lot of words to say. How we perform at the practice level is going to have impact in terms of how the ACO as a whole performs. And it's very important that we pay attention to that. If you're going to be part of the ACO, you're going to make that commitment to put forth that effort. We are also looking at, what are the different payment models in terms of the retrospective payment? What's a prospective and capitated? So I just want to share an example in terms of what our practice did before we really launched into this. So in our practice, we participated in a prospective payment model, and we can go to the next slide that's going to highlight it. And so in that model, one of the things that we said, okay, we're going to focus in on hypertension. The most difficult metric in my community, my patient population. And we said, how are we going to do this? And just as Dr. Mercado said, so we're going to have the physician-led champion collaborative. We put together that team. It was actually included one of the health plans employed population specialists, our own practice employed population health administrator, and we hired an RN just for this. And she was the one to help coordinate. But one of the things that the plan said was we're going to not only provide that upfront support, but they also provided upfront payment to allow us to put all of it together. And we actually saw improvement in our metrics beyond the target goals that we were looking to achieve, where hypertension at that time was 139 over 89. And so that's just an example of a prospective model. In terms of, is this practice ready? Yes, we were ready. We were ready to increase our risk. And we could go to the next slide. And so our arrangements are most effective when the payments are provided to the VBC entities as close to the behavior change and managing the cost and quality as possible. What does that say? When a practice has achieved those quality metrics and they've crossed the quality gates, they want to see payment. And 2 years later or 3 years later to say, okay, what we did, oh yeah, it was really good 3 years ago. So I don't even remember what I did 3 years ago. And so if we're really going to affect the change of behavior, we really want to see it as close to, as possible as we can for those payments. The savings and losses are reconciled months after the end of the performance year. And that can put a strain on that initial investment. And some of the practices are saying, I can't keep up with what we have put forth. For example, we hired an RN. Can I continue to pay that RN? Yet I have yet to see the payment to support her salary. So those are some challenges. We could go to the next slide. And so some of the best practices, okay, so structure the timing and method of payment to address the specific goals that we seek. Include prospective payments in those models. If you can arrange that, it did make a difference for us. Adjust the payments to account for the complexity of the patient population. We've said that a few times now. Recognize who you're taking care of and make sure that you're getting paid for taking care of that level of complexity. And then evaluate those high value service areas that may require additional investment, or particularly if we're going to have capitation rates. And then conduct those preliminary reconciliation. Don't wait until you get right down to the end of the negotiations and now you're saying, okay, we're going to take what we get. No, go back and try to do some reconciliation. And then share that data set. And again, we've said it before, appeals process. All is not done at the end. We should be able to negotiate and put forth appeals so that we could actually see some earned savings, and make sure, keep it transparent. Make sure that all of the docs, all of the practices are part of that process. And we could go to the next slide. Okay.
So thank you so much, Dr. Smith. Just to round things out, we do want to share a few of the some practical suggestions to improve provider engagement. It's really important to really have your practices, either your employed providers, independent providers, remain engaged in this value-based care work. Some things that we've done before is value-based scorecards and making sure that shared savings are also distributed at the proper timing, as Dr. Smith mentioned earlier. We have specific programs like attestation forms and quality sprints that really incentivize that quality work and making sure that our practices are seeing the patients that we have value-based arrangements for. And we even have some provider education incentives, to make sure that they get the education that's needed. We also provide some care management and care coordination services, so that's certainly an option for some of the ACOs and something that you can ask for with your participating ACO, because that does really move the needle. If you go to the next slide. Value-based education is really important. So you want to make sure everybody knows the why behind all of this work that we're doing. It's not just quality improvement, it's also HEC education, which is really important. And then it's not all about the money, right? We want to make sure that we're also providing data. I think data is very valuable for any primary care provider practice, any physician practice. Care gap lists are also important, that you're able to share that with your participating provider. Any EHR enhancements, especially those that reduce administrative burden, is also important. We've also looked at robotic process automation. So for some of our practices that have an advanced EHR, they're able to do some automation to make sure that the quality is improved that way. Go to the next slide. So just the key challenges, you want to make sure you identify the most effective ways to incentivize, value-based care goals among your practices, whether employed or independent, and just making sure that you're creating sufficient incentives for them to do the work, because it can get taxing, it can get tiring. You also want to recognize the resource limitations and making sure that you have enough of the infrastructure to successfully navigate through these challenges. So next slide. So in summary, you want to make sure you're providing that education, because that does help incentivize this value-based care work. You also want to develop objective criteria and also feedback in all of the work that you're doing. You want to combine incentives and make them as similar as possible. Our group takes care of a lot of different value-based care agreements. We have a value-based care agreement for every insurance plan that we have, and we try to align them as much as possible to make it less confusing for our practices. And then you can use a combination of factors to provide that incentive in the end. So it could be a matter of size. So if the practice that you're partnering with has 5,000, that 5,000 patients, that's certainly a component. And then the performance is also a really big component. And one thing that I want to make sure I also leave with is you also want to reward the staff, or you want to remind the practices to reward their staff. As you know, our nurses and back office staff, our MAs, do a lot of the work also for value-based care, and you want to make sure that you share that reward with your staff as well. Thank you so much. So go to the next slide. We're open for questions.
Well, thank you, Dr. Mercado and Dr. Smith. I'm sure for many folks on the line, that's a lot of information, right? And that was only 4 of the 7 domains that we've covered in only those 1 playbooks. And I will do a friendly plug that I think I heard both of you talk about, just the importance of data, accessing the data, actionability of data, which is a totally separate playbook that we also developed in the same initiative, and we'll be covering later this year some of those kind of best practices. But as mentioned in the chat, really encourage folks to submit any questions they may have. I know we're running short on time, so I'm going to do my best to get through as many as possible. But I know one of the questions that came through, and we'll put this out to both of you all, is just the challenge around levels of financial risk, depending on the type of practice you are, especially for specialists. That may not necessarily cover the total cost of care for patient populations. Taking on increased levels of risk, especially downside risk, can be challenging. Can either of you talk about some concrete steps or opportunities for either particular specialists or Dr. Smith for independent practices where taking on additional risk can be challenging? What are some key concrete suggestions that you all have for those types of practice entities?
Well, I could go ahead and start off. Let me start with the specialist component. So many of our practices in our VBC entities are, some may be multi-specialty. And for example, if we're working with a nephrologist and it's with the primary care practice, we're all looking at hypertension. We're all looking at blood pressures across the board. We all have that opportunity to make modifications in terms of our clinical protocol. And so that actually adds benefit at the end for the ACO as a whole. And I have seen some of our large multi-specialty practices do this quite well. Again, everybody has to be at the table, everybody's on board. It's not the job of the family physician to modify the hypertension medications. It's the job of every doctor who that patient sees and the patient encounters. And in terms of the risk question, I think, again, getting back to knowing what is knowing your practice financial status. What are you able to do? And looking for the value-based care payment to accentuate your current income. And we have to be careful with that because so many sign up and they get that wonderful, oh, I'm going to have an additional so many thousands of dollars at the end of the year. Well, no, you need to make sure that if you're in a fee-for-service market, that you are maximizing your fee-for-service behavior.
Yeah, so first off, I love that question, especially for surgical practices. Yeah, I mean, there are bundled payments. There are opportunities out there where you can have, additional income for taking care of the patient. In terms of getting the big data, I think it's right to ask for it, either from the ACO or from your payer for that type of data, because you want to know where your opportunities lies. Is it post-infection, or is it post-procedure? Is it after the procedure? Do you want to make sure that your patients are optimized before? Right. So do you want to invest in patient education or making sure that your navigator takes care of the patient beforehand? You want to make sure that their hemoglobin A1C is lower before operating on them, and then afterwards, Are they going into the right skilled nursing facility? So all of these things can all be revealed through data, and then by utilizing care managers or even community health workers are able to address some of these gaps and make sure that your patient is taken care of, and your overall cost utilization, your post-op costs are really lowered, and you're able to succeed.
Absolutely. And I think, we talked in the playbooks, it's a spectrum, right, of risk, right? And you should be matching what works best for you, your resources, your patient populations with these arrangements. It's not a one size fits all method to just have all these types of arrangements and settings just automatically take on two-sided risk. Part of that risk also gets into the engagement both at the organization and the individual level. And I know Dr. Mercado, we went through a little bit quickly towards the kind of incentive structure, but I think, as part of the discussions we had at the working group, that of all the domains in the playbook, I think was an area that's still ripe for additional conversations. I think many organizations are still trying to find that secret sauce to engage and incentivize those folks that are participating appropriately. What are some good strategies you've had, and as part of that strategy, to present outcomes data for those folks that are participating or their performance metrics? What have you seen that has worked well? What hasn't necessarily worked, and what are you trying to potentially evolve moving forward as you continue to try to find that right secret sauce for that engagement?
I mean, a couple of things. You always want to start with transparency and making sure that all of the data is available, and they can see why they received X amount of payment versus Y amount of payment. The other thing, and Karen mentioned this, is timing, making sure that it's closer to the work that they're actually doing, just emphasizing what Dr. Smith said. Those two elements are really important. And then, you also want to continue the education and making sure that they understand the why, because physicians want to take care of patients. They want to provide really good care. And linking value-based care and value-based care payments to the really, to the heart of what we're doing as physicians is really important, because we are transforming lives, we're making lives better, and we're getting rewarded for it. And it's not just that hamster wheel of fee for service that a lot of us physicians, feel burnt out about. It's more about taking care of that patient.
Absolutely. Dr. Smith, any thoughts there?
I do want to add on. So recently, we have been able to see our data on a weekly basis. That's from the ACO derived level data. And it's kind of nice to look at those metrics and to see, you're going from the yellow and you're going to the green. And we put
Yes.
that up in huddle every Monday. And it's like the team goes in there Monday. What is our performance? How are we doing with ED utilization? Do we have a decrease? Do we have an increase? And so they see this. And so we're getting that weekly feedback, and everybody's excited. Now, I'm probably the only one thinking about how this is going to transform into enhanced payment, but the team's not thinking of that. So they're getting that weekly feedback. They're calling those patients within 24 hours of discharge. This is what we see as a whole.
Yeah. And competition works too. So I mentioned that we have a scorecard. So every clinic has a scorecard, every physician has a scorecard, and they compare scores. They see, my hypertension rates, they see my hemoglobin A1C rates, and it matters. It incentivizes them. We also have quality sprints where if we have a hemoglobin A1C challenge, and everybody gets a pizza party on the top performers. So it's incentives like that really drive performance change.
I think, what we talked about too is, and I think you've highlighted that incentives don't have to be financial, that there's a lot of elements there, competition, even getting access to data, as we talked about, Dr. Smith, getting access to that data weekly is huge and not necessarily common across the board. And I think that's a huge part of creating additional access to the type of information that is necessary to succeed, and just alleviating some of these administrative burdens. All those things can incentivize and engage folks to participate and succeed in these arrangements. It doesn't just have to do with the topic we talked about before in terms of the levels of financial risk. There's other ways to really kind of move the needle forward and try to achieve these end goals. So I know we're close to at time. There's all sorts of different topic areas we could cover. I'll just leave with one remaining question for you all. It's just, what has been the most rewarding experience from your all's perspective in participating in these arrangements? And what are you kind of looking forward to as you continue your journey within value-based care? Let's start with Dr. Smith, and we can end with Dr. Mercado.
Perfect. I think the reward that I have seen is literally the progression of technology alongside the VBC arrangements. For example, instituting AI. And I mean, that alone with the documentation, chart closure, getting rid of some of that burden that we see in terms of the administrative burden that physicians are suffering through. So the technology, and how do you integrate that? How do you think about other ways in which to provide care, utilizing the care coordinator? How do you bring a RN on a small practice like my own and actually see the benefit of that? And getting the shared solutions from my colleagues. We share more of wins, but we also talk about some of our other burdens. And so it's not like it's just on me, it's my colleagues, and we're able to support each other. So those are the three components that I see: the technology, improvement in terms of our workforce, and then just being able to collaborate with other colleagues and other practices.
I think for me, it's being able to provide other services that really help our colleagues, our physician colleagues, our provider colleagues, like care management and community health workers. Without our value-based care arrangements, without this focus away from fee-for-service to value-based care, I'm not sure if we would have invested in care managers or clinical pharmacists or community health workers or behavioral health counselors, social workers. All of those investments made a lot more sense when we did that move to value-based care and invested in value-based care, and being able to provide those services to where I'm able to send my patient who's having a mental health crisis to a social worker in my clinic, versus waiting 2 weeks, 2 months for a social worker outside. Is very rewarding, and I'm sure our colleagues appreciate that when they have all of those resources in hand, because of value-based care arrangements.
Excellent. Well, I want to thank you both again for sharing your experiences and insights with this group. Conversation continues. There's a lot of work to still be done, and the AMA and other partners are committed to helping practices like yours and organizations like yours succeed within these arrangements. So with that, I'll pass it back to Alec to close this out.
Awesome. Thank you, Chris. Thank you to both of our speakers for your time and expertise today. When we conclude today, you will see our feedback survey. Please take the time to answer the 2 questions there. Your responses will help guide our upcoming programming to deliver the webinars you want to see, such as the one you saw today. This recording will be available to review on demand with the link to use to join today, including access to today's slides and recommended resources by selecting that resources button in your Zoom toolbar. Our value-based care series returns later this year on November 4th. Our experts will explore how healthcare organizations can integrate behavioral health into their value-based care arrangements, and how they approach challenges to integration on the path towards evidence-based, preventative, and equitable whole person care. You can scan this QR code to register now, or follow the link in the Resources tab, which will take you to all of our upcoming and past events this year. Finally, if you are looking for something a little more in person to do, here at AMA Steps Forward, we would like to invite all attendees today to join us for our next Saving Time Practice Innovation Bootcamp in Chicago this September. This 2-day in-person bootcamp is specifically designed for clinical and operational change agents looking to eliminate unnecessary work and free up more time to focus on patient care. If you have interest in attending, scan the code on the slide right now or follow the link in the Resources tab. For additional resources and guidance to support your physicians and staff, including those on value-based care, please visit the American Medical Association website or stepsforward.org. We thank you again for joining us and hope to see you again soon.